So good morning to all of you. Today we are going to discuss the one overview of the endoscopy, in which I will just demonstrate you the instrument design and little about the history of endoscopy, what is the present status and what is going to be in the future of endoscopy. And after that, the physicians who come for endoscopy course, they will do the hands-on the animal today, the upper GI endoscopy, and the surgeons, they will perform next day. And today the surgeons, they will have robotic. So, but this is the combined lecture in which we will discuss an overview of endoscopy. Definition already you know. It's a minimally invasive diagnostic medical procedure to use to assess the interior surface of the hollow organ through the natural orifices of the body. So this is the definition of endoscopy. Endoscopy alone is a diagnostic medical procedure. If you do any operative thing, it will be called as therapeutic endoscopy. But alone endoscopy is a minimally invasive diagnostic medical procedure. It was first invented by Philip Bourgeois in 1806. And he has invented this fiberoptic first endoscope in the history of medicine. And then William Beaumont started doing a lot of oesophagoescopy, and it was the year 1822. At that time, first endoscopy on the human was successfully started, and that was also by William Beaumont. There are many types of endoscope, as we know: fiberoptic endoscope, video endoscope, capsule endoscope, transcanal endoscope, double balloon endoscope. These all type of endoscopes are available. The fiberoptic endoscope is the first endoscope which was invented. And at that time when endoscope was invented, there was no TV, no camera, no any video recorders. So at that time, the fiber optic was used, and as we know that fiber optic word is basically, fiber optic was invented by one aircraft company, and fiber optic works on the total internal deflection. As we know, light cannot travel to the curved pathway, but if diameter of any transmitting medium of light is less than 5 micron, then light will be reflected by the internal surface of that medium, and that is called as total internal deflection. And this total internal deflection has given this capacity to do the endoscopy. And this is important, that light should be completely bent all around, and it has a central fiber endoscope. Central fibers are for image, this is for image, and peripheral fibers are for light, to emit the light. And this was a primitive fiber optic endoscope. Here we can see it's a very good, it's a cheaper alternative. You can see by naked eye. It is very good for freelancers who carry the endoscope from one hospital to another. They can carry it in a formalin chamber and they can go. You don't need any monitor, you don't need any processor, you can see just by naked eye. And if you want to buy a good quality fiber optic endoscope, it will hardly cost you approximately $1,000. In $1,000 you can buy one fiber optic. Disadvantage is that there is no any digital enhancement. You don't have any digital enhancement. Digitally there is no any electronic part inside. It's a completely optics. So in those situations, if you want to increase the shutter speed, decrease the shutter speed, want to increase the aperture, want to increase the brightness, these features, contrast, these features you cannot do, because there is no any electronic circuit. It is a complete optics. Another problem is difficult to teach. If you want to teach someone, you have to attach one extra ad, and that will be seen by your assistant or your resident, and then only you can teach him. There is nothing on the monitor. Third disadvantage is that you don't have any data capture. You cannot prove to the patient that you have this ulcer C and this is a perforation or this is candidiasis or whatever or hiatus hernia. You have a sketch, and that sketch has the complete GIT sketch, and you will write ulcer, you write hiatus hernia, that's all. So basically it is obsolete. Nobody today use fiber optic endoscope except in the remote places where the money is the main concern, it is used. Now everywhere video endoscope has been introduced. Video endoscope is very good. Video endoscope has big advantage that you can even through the particular wavelength also, that is called as narrow band imaging technology. If you want to see carcinoma in situ, I will show you later in this presentation, you can throw the different wavelength of the light and that will give you beautiful image. Another big advantage of this is that aperture can be set, fibroscope filter can be set, shutter speed you can decrease or increase. If the light is less, you will decrease the shutter speed, light is more, increase the shutter speed. You can record, there is an inbuilt hard disk also. In this all the data can be recorded. You can program the processor according to your name and you can save it there. And whenever you want to call, it will be called. So it is having unlimited power. Nowadays 4K completely ultra high definition endoscopes are also available. Capsule endoscope. Capsule endoscope was invented by Paul Swan and Gabby Eden simultaneously. This is a very typical invention where two inventors invented the same invention at the same time and both were credited to invent it. Initially the patent registrar has thought that one must has copied the another technology, but when they saw the research methodology, they found that both of their research methodology was independent to each other. And both were credited to invent this. When capsule endoscope was invented, it was thought it will revolutionize the method of endoscopy. It has this is the LED lights. This is the light of the capsule endoscope. This is lens. Here is the lens, and this is CCD. This square is CCD. Here this is square. Square CCD means charge coupled device. This is CCD. That is the retina of the endoscope which take the image and transfer the photon into electron. And there is an antenna. This antenna can radiate the Bluetooth also. Wireless, it can transmit the image. While traveling through the GIT, it can transmit the image to the computer. And not only that, it can store the data which you can, there is a chip which you can retrieve after retrieving the capsule endoscope. And you have a two battery. This is one battery, this is second battery. And length is 1 inch. 1 inch is the length and the width is ½ inch. So it's a beautiful endoscope, and especially when the conventional upper GI endoscope is not possible, it's a good alternative. Like suppose patient has severe cervical spondylitis, or patient is psychiatric, or you have to see terminal ileum where the conventional endoscope cannot reach. In those situations, capsule endoscopy is good. US FDA has approved the use of this endoscope in year 2001. When it was introduced, it was thought that it will revolutionize and it will be so popular that all over the world this manual endoscopy will almost stop. But this didn't happen like that. And ultimately, it is a flop. It is only pushed by the company, and it is only a specific indication is there. This is the capsule. This capsule has, this is from Olympus, and this capsule has one lens here, and this lens has a good shutter speed. Battery life is 12 hours, and patient has to swallow it, and after that it will take thousands of pictures, and it will store the data and transmit. 80,000 to 140,000 picture is taken within the travel through the GIT, and it is high quality picture. And after that, once it is traveling, then it has a complete descent, and it will take from all around complete 360 degree, and then it will come out. So this is a very good endoscopic technology, and slowly this technology is more getting advanced, and in the future it will take it completely 3-dimensional pictures. Right now it is not possible, but completely 3D image it will draw, and ultimately it will come out through the anus and it will be discarded. But it has its own problem. It has a problem that 65 to 85% of a specific pathology is missed. If it is a generalized pathology, it is good. But if it is a specific identical single pathology, it will be missed. Like suppose single point GI bleeding is there. There is a huge chance that it will be missed by this. Reason being, here we cannot distend the lumen of the GIT. In our conventional endoscopy, whenever you have to diagnose, you can stop, you can take your time, you can inflate the bowel loop, you can have a look, you can irrigate and suck and clean the mucosa, you can discuss with your colleague, you can take a biopsy, you can keep your opinion reserved. After 2 days you can give your opinion once you consult some other specialist, show the picture, and that is fantastic. But here it is not possible, because it's a collapsed lumen, completely collapsed lumen, and you don't have any time to retain. You just a flash photography, it is there. Just like simple example, if someone will give you a digital camera, high definition, and with the parachute you will jump out of your aeroplane, and you are dropping down, and your task is that you have to take the picture of all the birds in the sky. Now this is your luck. When you are shooting, at that time, if you are at appropriate time, at appropriate place, this picture of the beautiful bird will come. But at that time, if your head was down or moving other side, dropping down, it is missed. Similarly, it is the problem that you cannot control manually when to stop, when to inflate, when to... So this is basically only in the patient where the conventional endoscopy is contraindicated. Another problem is that capsule retention also occur. 1.4% of the cases, capsule retention occur. Now double balloon endoscopy. It was invented by a physician whose name was Yamamoto. And Yamamoto has invented it in year 2000, and it has 2 balloons. One is inner balloon, other is outer balloon. Yamamoto has got the inspiration of inventing this by earthworm. The earthworm, if you see, it can crawl over the earth. How? That first it will stretch the upper body fixed to the earth and then pull the lower body. Exactly same way, first you will stretch the inner tube and inflate this balloon, deflate the outer balloon, and it will stretch the outer balloon. Again inflate the outer balloon, deflate the inner balloon and push the inner balloon. So this way successively inflating, distending, deflating, distending, deflating, you can reach up to the terminal ileum. One of the very good company which is making it Fuji, and other companies are also there. Here we can see that this is a double balloon endoscopy, how it is going. So this is the outer balloon which is inflated. Now this is inner balloon which is inflated, outer will be deflated, and it will keep on progressing throughout the GIT. Problem of our endoscope is that we cannot cross ahead of the second part of duodenum. Reason being that after second part of the duodenum, third part has a complete U-turn. It's a complete bend. And then there will be looping effect. There will be looping effect and you will not be able to do. But here you can go up to the terminal ileum also. And it is not only pushing the endoscope, it is pulling the intestine also nearer. So in the conventional endoscope it is not possible. Like here we have the conventional endoscope, and we can see that if we will push it in here, it is progressing. But if it is a complete U-turn, and then it is looping effect. Even looping effect happens even in the splenic flexor and hepatic flexor of colon, but that is only 90-degree bend. So if it is not going, you can withdraw it, you can rotate it and again try, it will go. But duodenum, it is not possible because it is a 180-degree bend, complete U-turn, and in those situations there will be looping effect. This loop will start pushing it and it won't progress. So in the small intestine, this is important to do this double balloon endoscopy many times. The indications are: allow the visualization of entire small bowel up to terminal ileum, allow the sampling or biopsying of a small bowel mucosa, then resection of the polyps on the terminal ileum, and placement of a stent, or sometime if you have done a Billroth 2 type enterotomy, then it is used for a stricture dilatation also. The stricture with the balloon, you can dilate it also. Or you did Meckel's diverticulum and you cut more and there is a stricture, you can go and you can dilate it also. So these are the very good indication of the double balloon endoscopy. But sometime, some company, one of the leading company is Fuji. Now they are making the air pressure. But in old time, old endoscope, double balloon has a wire to inflate the balloon. And that wire sometime the balloon get punctured and this wire sometime perforates the bowel. So it is also not completely risk free and you have to do it in a specific indication. Every patient you should not do the double balloon endoscopy. Now ERCP. ERCP has revolutionized the way how the CBD pathology was dealt before. ERCP endoscope has a side viewing endoscope. We can see here we have the ERCP, and normal endoscope, conventional endoscope has a, this is the front viewing, but in the ERCP it is side viewing. This is side viewing, it is on the side here. So before going in detail, let me demonstrate you the instrument yourself, and then we will go in the detail of the presentation. So although you might have been demonstrated Dr. Khurana has demonstrated you the instrument design, you have been demonstrated, the endoscopist, no? It was demonstrated. So but I am going to demonstrate you again right now, and the basics we will demonstrate you. So how the endoscope works and what are the different. So this is called as control unit, control panel, and it has two wheels. This is a larger angulation wheel and this is a smaller angulation wheel. The larger angulation wheel is used for up and down. This is for up and down. So this is the tip of the endoscope. Here we can see we are holding it at this point like that. Here this is endoscope. And when I will just move the larger angulation wheel, this is up, and here this is down. So larger angulation wheel, when you move it towards you, it will move up, and the up is 180 degree possible, 180 degree. So when I am moving towards me, it is up. When I am moving towards away to me, it is down. How to do? You don't have to use your right hand. You have to use the left hand. The proximal part of the thumb will be used to rotate the upper wheel, and distal part of the thumb will be used to rotate the smaller wheel. This part of the thumb will be used to rotate the upper wheel, and this part of the thumb will be used to rotate the lower wheel. Here see, both the wheel I can rotate by the simple thumb, because your right hand should be free. Why? To introduce the endoscope, to feel the giving way sensation and to feel the resistance. So again coming back here to the same point, that this is the, right now because I am holding with by left hand, so I will show you. When you rotate it towards you, it is up. When you rotate away from you, it is down. And up is 180 degree, down, left and right is always only 90 degree. Now when you move it up, and if you want to lock it, there is a button here and it is locked. Now see, I am not holding it, but still it is locked. This is the button here, this is a long lock button here, and this is unlocked, and this is locked, this is unlocked. So this is for locking and unlocking the outer angulation wheel. This is outer angulation. Now this is a smaller angulation wheel for left and for right. If you move towards you, it will move left. If you move away from you, this is left, and if you move away from you, it will right. If you move anti-clockwise, it is left, and if you move clockwise, it is right. The larger angulation wheel, if you move anti-clockwise, it is up, and if you rotate clockwise, it is down. Now here is a lock for left and right. Suppose you are bending it to left and I want to be staying in this position, I will lock it, and after that it will remain there like that. And then I can use instrumentation, I can put it. So this angulation wheel is same in every patient and in every endoscope. If you want upper GI endoscope, lower GI endoscope, ERCP, bronchoscope, choledocoscope, pediatric endoscopes, this angulation wheel is similar. Even in the notes, natural orifices transluminal endoscopic surgery, in that also this angulation wheel is similar. After that you have two here button. The towards you is suction, away from you is irrigation. This is a rule. Even in laparoscopy, when you pull towards you, it is suction, push away from you is irrigation. Now this irrigation is of two types. One is irrigation of air, another is irrigation of fluid. If you merely just put the finger over that, then it will be only air going there. But if you press it by your finger, you can see there is a hole there. So if you just occlude this opening, this hole, then air will go psss. And when you press it, fluid will go. That fluid is in the bottle. That bottle will be connected to the processor. Here this is the bottle for the fluid, and in this fluid bottle you can attach anything. You can keep the simple normal saline, ringer lactate, or some medication, antiseptic, astringent, many things can be used, and it will be attached there. So when I will press it, the fluid from this bottle will be ejected. So after that, there is no eyepiece. In fiberoptic endoscope, there is an eyepiece here. You can see this is eyepiece. An eyepiece I can see by naked eye here like that. But here there is no eyepiece, nothing. It is blind, it is closed. And you must have to have a monitor. Now it has 4 buttons. This is button number 1. Here it is written. This is button number 2. At this it will be written. Button number 3, button number 4. What is these buttons for? This is button for programming. How to program? I will show you right now how to program. These are the buttons. Programming I will show you once I will finish the lecture. Then see, here it is written number 1. Can you see that? This is 1. This is here written number 2. Here it is written number 3. And here it is written number 4. So these are the 4 digital buttons. These digital buttons are, you have to learn how to program. Because there is no fixed function of these buttons. You have to program. Because same button can be used for different function. Same button you can use for freeze. Same button you can use for increasing the shutter speed. Same button you can use for printing a image, and same button you can use for recording the video. So you can assign your function according to your habit. And you can put your name and you can save it by your name in the endoscope. So how to do? We will demonstrate you. So they are digital buttons. After that, last thing is here, there is one channel. This channel is for instrumentation. You can open it. Once it is not in use, always close this channel closed. Never keep it open unless until it is in use. And you have the different instrument. First instrument which you should introduce is the cleaning brush. This is the cleaning brush I am putting it, and it will come in front. And here now slowly this brush is out. See, it is out. So every time before doing endoscopy and after doing endoscopy, you should must clean the channel once, because you never know your assistant might not have cleaned properly, and it may have some blood clot at debris or wrong thing. Another, that other channel may obstruct and it can break. So first to clean. After that you have a various instrument. You can put it biopsy forceps, you have seizures, you have needle to give the injection of vasopressin, then you have the graspers to pull the foreign body, and for dentures or the, see here this is the instrument, and this is which instrument? Open the jaw, see the jaw is opening and closing. This is grasper. Similarly you have a biopsy forceps. Similarly you have a needle to inject vasopressin. Similarly you have loop electrode. Loop electrode will needle. This is, and here you go, this is loop electrode needle, vasopressin, needle. So this is needle, and you will not hold the handle part, that assistant on your command he will inject it. You are only allowed to hold this here, and we can see here a needle will come out. Just let me give the contrast. Yes, see this is needle, very sharp needle. This needle is coming out. This is needle. Bahar karo, andar karo. And you can attach the syringe here. And then you can inject the, suppose there is a varicose bleeding, you can inject the vasopressin with this needle. And polypectomy also, on the base of the polyp you will inject the needle. How to inject it? We will do hands on today, and you will inject yourself. Now another instrument you have, a sneer electrode. Suppose you have a polyp, you can do polypectomy. Here these are the sneer electrode, and here you can attach the monopolar cable. It is attached, and this will go to your machine, your high frequency electrosurgical generator. And again this is very useful instrument, and it can be used for polyp or sometime for fulguration. Suppose you want bleeding to stop by current, then you want the tip of this endoscope to fulgurate. So it is coming out, and here it is out, and suppose this finger is polyp. So now it will go and you will just hang, and now pull. See, now finger is caught. Pull karo or pull. See, it is caught now, like a rudder's knot. And after that you will apply the paddle current, coagulation current, and it will coagulate also, and it will cut. Just like how ENT surgeon, they remove nasal polyp with a sneer, same way. Open karo. Now once it is open, it can come out. So this is a loop which you have to activate, and you do the polypectomy. Now suppose you want to do fulguration. Andar karo thoda sa. Or yes, that much only. Now it is a fulgurator. It acts as a spatula, and if you are bleeding, you can fulgurate, and by fulguration you have to change the machine fulguration mode, that is a spray mode, and then electron will jump from the tip, and it will give a 6 times more width of injury and less depth of injury. So there will be no perforation, and the bleeding will stop. So you have a various instrument to do the channel, and through the channel you can use flexible instrument, and it can flex very nicely, and it can reach up to there. So this is, if you are not using it, then it should be closed. This is closed. So this is regarding this control panel of the endoscope. After that coming, there you have a shaft. This is shaft, and shaft is the main difference in various endoscopes. Like length of the shaft of the upper GI endoscope is 1 meter, and length of the shaft of the lower GI endoscopy is 1.5 meter. Diameter of the upper GI endoscopy is 8.9 mm, and diameter of the lower GI endoscopy is 10.8 mm. That is almost 10 mm to 11. Company by company 1 millimeter plus minus it varies, diameter. So only difference in various endoscope is the shaft. This control panel will be same in every endoscope, and shaft could be the, like suppose you have bronchoscope, then it is only 75 centimeter and 3.2 millimeter. Nowadays even the nasal endoscopes are available, which you don't need to go through the mouth, you can go through the nose only, just like a rice tube, and you can do endoscopy. So these are possible. Now coming on the tip. On the tip of this endoscope, there are various parts. So on the tip of the endoscope, you have 5 important points which you need to remember. So we will see the tip of the endoscope, how it is made up of. So this is the tip, and tip of endoscope has one CCD, 2 light, 1 working channel, that is the largest, and 1 fluid ejecting knob. This is a fluid ejecting knob. This is at the tip of the endoscope. This is CCD. CCD is today, nowadays it is also CMOS. New concept of CCD is CMOS, CCD. This is the working channel, that is instrument channel, through which you can put the instrument. This is instrument channel. And this is light number 1, light number 2. थोड़ा light on कर देना इसका. This is light. And here is the fluid ejecting knob. But peculiarity is that fluid ejecting knob direction, the fluid is opening on the side, not at the tip. So I will again show you all these structures on the tip, and so light come kar do abhi. If you see, there are 2 lights. Can you see 2 lights? There are 2 lights, and this is the working channel. This is the working channel. This is light number 1, light number 2, and this is CCD, and this is fluid ejecting knob. So light on karo halka sa. Then thoda sa on, thoda sa light. Yes. So this is 5 important. 1, 2, 3, 4 and 5. This is CCD, charge coupled device, glass lens, you can see the lens, and these are the 2 lights. So this fluid ejecting knob, what it does, that once you eject the fluid, fluid is not ejected in front, it is injected on the CCD. Purpose is it will keep on cleaning the CCD, so that if there is any bile or any fecal matter or any dirt, it will clean it here. So that's why it is important that the fluid should be ejected only when you have to clean the CCD. Other time you have to eject only the air, And this is all the 5 things is in every endoscope, it is similar. It is similar on every endoscope. So this is how these 5 important things are there on the endoscope. Now coming to the umbilical cord. This part processor se nikal ke umbilical cord dikhao. So now we will see the umbilical cord of the endoscope. So we have seen the control panel, we have seen the shaft, we have seen the tip, and this is now the umbilical cord. Umbilical cord is the actually the layman term. It is basically a adapter. And usko nikalo. And this is on the back of the endoscope. So if you will see the endoscope here, this is the other attachment, this is adapter, and this is important. This has various parts which I would like to share with you. This is the for taking light. Always in endoscopy, light source has inbuilt air pump, and this portion will go to the light source. And once it enters into the light source, Here we can see this is light source, and once you will enter into the light source, then this will be attached with the light bulb output, and this is attached with the air pump. So this will pump the air. What is the advantage? That always your air will be little hot, because the temperature of the light will be taken by the air, and it will keep on doing the light also cold. So it will balance the temperature. Air flow will balance the temperature of light, light will balance the temperature of air. So this is for attachment of light. Now this is called as male part of pigtail adapter. Pigtail adapter. This is pigtail adapter. It is called commonly pigtail adapter because it is looking like a tail of a pig. And here you have the female part of pigtail adapter, which you have to attach to the male part of pigtail adapter. How to attach? There is a yellow point here, this yellow point, and there is one yellow point in this. So both the yellow points should be together. Here you will go, it is attached, and now you will rotate it to the clockwise. Here it is clockwise. It is done, and to remove it anti-clockwise, come out. So you should not try to fit like that. It will break the tooth. Inside there are 20 pins, they will break. So what you do, this yellow point of the male part of the female part of pigtail adapter, this yellow point of, and this will go together and then rotate to the clockwise direction, it is fit. Now another, this is the male part of the pigtail that will go to the processor. And how it will go to the processor, we will show you. So this is adapter. Now, after that, there is one attachment here. This is for grounding. Grounding. There is one earthing of the machine that you will tight it here. Purpose of grounding is very important. If you will not do the grounding, and then if you are using electrosurgery, you are using coagulation and fulguration, and if there is any insulation failure anywhere, then patient may get burned. There may be perforation of the esophagus, there may be perforation of the stomach or duodenum. So always this ground has to be used. Just like in your fridge, there are 3 plugs, one positive, another negative, which is alternatingly changing in alternating current, and one is ground. So that if the body of the fridge or AC has a current, it will go to the ground and it will save you from electric shock. So this ground mainly are ignored by the physician, but that should be nicely attached. After that, here in this side, on the left side, there is attachment for fluid, and this is the fluid bottle, and this is the attachment. You go like that and rotate it and it will fix, and here it is done, it is attached, and this is in the bottle. You have a fluid, so now it will suck the fluid from this bottle and it will push it into the, how it happens? Due to vaporizing effect, because the air is flowing here. So due to the air flow, it will, as soon as you will push it, the button on the front, it will take the fluid from the bottle. How to detach it? Pull and rotate it. Without rotation, it won't come out. And other side is the suction. On the right side, it is suction. Left side is the irrigation. So again, I will show you. This is irrigation. This is irrigation. This is suction. This is male part of pigtail adapter. This is light, and this is air. So this is in the part of the main where it goes into the light source, and this will enter into the light source. Now how the processor will be attached? Processor will be attached by pigtail adapter. So this is how you will use the endoscope, and in every endoscope it is same. Only in ERCP, on the tip, there is some extra things are there. ERCP I will show you that in ERCP few extra things are there. What is those extra? I will show you. First thing is that here in the tip it is side weighing. So it is side, it won't be front. See, front is blind, front is completely blunt, it is only on the side. And there is one extra lever here, this lever. This is called as tip deflecting lever. Any instrument I will show you. Sometime what happened that in ERCP, when you put a stent, when you put a guide wire, when you put anything, then you want to angulate it, because it might not be going into the correct place. So in those situations you have to use it. So now we are going with the instrument here. Here, and after that, see, it is going straight. If it is going straight, how can I do the ERCP? So you can change the direction by this knob, and see, once I will pull it, it will change the direction right and left. I will like to show you here. See, it is bending. Can you see that? Tip of the instrument is bending. And that way I can deviate the angle, and after deviating the angle, it will be easy to negotiate through the ampulla, and then it can be introduced into the CVD. Or you can do a sphinctectomy, or you can put the guide wire. So here with this finger, this is extra knob. If you will push it, it will be straight. If you will pull it, it will become bend. Push it straight, pull, become bend. So this is extra. Otherwise, all the angulation wheel is same, and it is side wing endoscope. So this way you have the various endoscopes, and first thing what you should do is that you should try to fix it mouse de do jaldi, and then yes. So then this is the difference in the ERCP. Now when the ERCP was invented, it was thought that it is completely minimally invasive, it is going to do the miracles. It is true, but it is not as innocent as it was thought once upon a time. It is very strange that if you will do the literature review, that complication rate of ERCP versus laparoscopic CVD exploration, then ERCP is more complication rate compared to laparoscopic CVD exploration. ERCP mortality is also up to 0.5%. But still ERCP is gold standard. The reason is simple, that in the patient in whom it is successful, thereof quality of life is very good. So that is why this is a small risk of complication we are ready to accept. But it is not as innocent, because when you have to do a sphinctectomy, and a sphinctectomy has to be done at 11 o'clock position. When you do the sphinctectomy, it has a lot of complication like a stricture. Beginners, when they put the stent, initially it enter into the pancreatic duct. They inject the dye also, patient get pancreatitis, patient get cholangitis, patient get a stricture, patient get perforation and bleeding. These all complications are there. Now to overcome this complication, micro ERCP has been invented. What is that? Normal conventional ERCP is a blind procedure. We cannot see anything except ampulla of water. After that, it is radiological guidance. You have to inject a dye, put a fluoroscopy, you are seeing on the monitor, you are seeing filling defect, you are seeing the hepatobiliary tree, the dye is going. But now it is possible that inside the ERCP, one micro instrument can be introduced that will do the choledocoscopy. It can directly enter into the CVD, and it has its own channel for instrumentation. It has its own channel for instrumentation. So you can directly through the ERCP, you can through the endoscopy, you can put a choledocoscope, and then you can enter into the CVD. And nowadays you have ultrasonic lithotripters. Sometimes there is an incarcerated stone, we can break those incarcerated stone and we can suck it out. But of course, this is expensive technology, and this micro part of the endoscope is very fragile. After few surgery, it breaks. So that is why still in the developing country, the conventional ERCP is going on, where we do C-arm and under fluoroscopy, we perform ERCP. Now, pre-endoscopic preparation, already you know that before performing endoscopy, the nurse should explain what is going to happen, and it should be recording all the vital parameters. After that, you can do without sedation also. Sedation is not required in endoscopy, but if you will sedate, it is better. How to sedate? IV metazolam, pentazocine or pethidine and is cocktail. So IV metazolam or pentazocine or atropine also you can add, and just before the procedure you should start injecting IV. Nasal oxygen should be on. IV propofol, if the patient is not cooperative or patient is in ICU or patient is pediatric, then propofol anesthesia is the best way to perform endoscopy. We should avoid using antispasmodic drug during endoscopy. If you will put antispasmodic drug in the beginning during endoscopy, it is possible that endoscope will enter into the airway. And in spite of entering into the air, because muscles will be relaxed, and in spite of entering into the airway, there will be no gagging reflex, and you may do the disaster. So it is always recommended that once you enter into the stomach, after that you should put the antispasmodic medication, so that sphincter of OD will relax, pylorus also will relax, and then you have the better vision. So pre-medication is necessary. After that, patient should not eat or drink at least 4 to 6 hours before the upper GI endoscopy. And if you are doing the colonoscopy, at least clear fluid before 24 hours should be given. Polyethylene glycol, approximately 140 gram in 2 liter of the fluid should be given prior to the night of the procedure, at least 6 hours before the procedure. If you have to do in emergency, you don't have a time because patient has active bleeding, polyp bleeding in the colon, or patient has other problems, in those situations saline enema should be given. Remember, any time mannitol enema or soap water enema should be avoided, because one of the dangerous complications of the unknown soap water enema or saline enema is colonic explosion. Colonic explosion is a disaster which can happen if you use this type of enema. If you will search it, you will see hundreds of cases has already been colonic gas explosion is one of the disaster of the colonoscopy. And there are case report in which patient death also is reported, and in one of the case report, the surgeon himself or physician himself has broken the nose. So therapeutic colonoscopy with electrocautery is widely used. Adequate colonic cleansing is considered crucial factor of safety, and colonic gas explosion, although rare, is one of the most frightening iatrogenic complications. So why it happened? Because sometime when we use the unknown enema, it creates the methane gas production with the colonic flora, and when you do electrocautery, then methane get exploded. So always remember that polyethylene glycol should be used, and if you are doing an emergency, then you should use saline, not use any unknown soap or mannitol or any other enema. Now anesthesia. Local anesthetics should be sprayed on the throat, or you can use the xylocaine viscous to swallow the patient, and then you will start doing endoscopy. Now there is a huge list, exhaustive list of doing endoscopy. In my opinion, any patient may be who has the symptoms of upper GI a candidate of endoscopy. Even simple atypical chest pain and simple dyspepsia also may be the simple persistent nausea and vomiting also may be the indication of endoscopy. And of course, if it is a known case of hiatus hernia, stricture, tumor, ulcer, then it is already an indication. So any patient you want, you can do endoscopy. You don't need to explain that why you did it or whatever. Today it is one of the routine procedure which you may perform. Now I am going to show you the videos of endoscopy, but I will not be able to show all the pathology. So I am just going to demonstrate you. Already the physicians, your username and password has activated. Have you been there to see what is there? No? So I will just show you where is the endoscopic resources. Endoscopic resources, we have put thousands of study material for you to go after, even after going from here, and how to use it, that I would like to share with you so that you can use it properly. So you will put your username and password, and after that you will go to the website. You can change your password anytime from here. You can update new password, or if they have mistaken your name, you can change it. Then you go to subscription and then you click it here. Once you, there are 3 subscription, articles and journal of all the surgical endoscopy, that also you can retrieve, hundreds, thousands of articles of surgical endoscopy. Now you go here and you go to the books and books of endoscopy. Almost all the good atlas of endoscopy we have kept there. And it is always recommended that you should remember those, all the pictures, because endoscopy is basically mostly a diagnostic procedure, and you can only diagnose if your brain knows, because if your brain knows, only then I can see. And these all atlas is beautiful atlas which you should completely frame in your brain, so that during colonoscopy or upper GI, if you see that, you can, this all we have purchased for you and we kept it there. Now you have videos. These are endoscopic videos. There are hundreds of endoscopic videos which we have kept there, which you can download. Almost all the endoscopic procedure which you can do, these videos are there. There are upper few videos are very good. Basic movement of colonoscopy, forbidden movement. Forbidden movement means which type of movement you should not do. Sometimes what we do, that we use wrong finger for wrong button, wrong finger for wrong wheel. And once your habit will be wrong, then unlearning is more difficult. So these basic movements and exercises, there are few exercises which will give you right turn shortening, avoid sigmoid loop formation, passing the sigmoid loop, shortening the transverse colon, and basics. These are very important. So you must go download those videos and try to read this, and it will be a good resource. Not only that, every month we keep on adding extra videos. Another beautiful support what we have given for our laparoscopy as well as endoscopic surgeons, as well as robotic surgeons, that this is a share your file with the faculty. What happens, that suppose you did endoscopy, and after doing endoscopy you are confused with the diagnosis, and you have a picture, already picture taken, just you go, you put your name and choose your picture and upload it here. So let us see if there is any picture here or not. Let me take one picture. Suppose there is endoscopy ulcer, and suppose this was your picture here, which you are confused that what is this, ulcer or candidiasis or what, and sometime even the patient has taken a antacid, that also looks same. So you save it and it is saved. Suppose this is your picture, just you go choose the file and upload it. And you can use up to 2 GB file you can upload. Once you will upload one file, another will open. And again you can choose another, and again third will open, like that. So after choosing the file, type your question, please explain the diagnostic or whatever diagnosis of this endoscopic picture. And do you know what happens? One copy comes to us, one copy goes to you, and one copy we forward to Professor Khurrana. And then you begin upload, and it is uploading now. And upload is in progress. Do not close this window and upload it. And now within few hours you have the answer. That you can do even you have put a port wrong, or you did some surgery and there was perforation of, then you can ask, you can upload the video also, and then we will check it and we will be able to help you. To patient you can say that diagnosis is reserved, I have taken a biopsy, next day I will tell you. So this way, if you want, next day you go to the download section and you select your videos, these were the videos, and go here and delete it, and it will be now deleted. Or if you have wrongly uploaded, then it will be deleted now, and it is deleted. No file, 0. And this will be in between you and us. Nobody else can see it because this is your member area. So that way you have the different, there are a lot of other features also, but I will not go in that detail. So you should try to explore. So all the videos you should try to see. So I will not go in detail of the every procedure, but little brief I will just like to tell you. So here you enter into the stomach. In the stomach you will see the gastric, that is rhusis here. This is the longitudinal fold in the stomach. This is visible in the body of the antrum part. It won't be visible. In the antrum there is no longitudinal folds. After that you will enter into the pylorus. First part of the pylorus you will see the ampulla. Then you go and you can only reach up to the second part. After second part, no way, because there is a complete U-turn. Most of the time in endoscopy, we should do diagnosis at the time of coming out, not at the time of going in. We should do at the time of coming out, because during coming out, you are relaxed. And then anywhere you can stop, you can take a biopsy, you can do just like a police when they come to search somewhere. Then initially they don't do any arresting or they don't do any seizing. First they come easily and they inspect everything. Just before quitting, they will do the arresting or seizing, because during entry if they will do that, there will be chaos, a lot of problem, people will come, disturb, vision will be bad. Exactly same way during entry, you should not take a biopsy or you should not do anything or you should not try to spend your time. Initially, you should try to enter as soon as possible to the remote destination. And while you are withdrawing, take your time to do diagnosis. So here it is coming out, and this patient has a cholangiocarcinoma here. This is the cholangiocarcinoma. Then you can take the biopsy, then you can take it out. Sometimes you might have denture, sometimes you might have the coins, you might have foreign body, you might have some other pathology. And that is, here you can see there are multiple coins, you can pull it and take it out. So there are sometimes chances that you have to diagnose the hiatus hernia. Hiatus hernia will be done by J maneuver. You have to enter into the stomach, and there is one problem in endoscope. Problem in the endoscope that once the upper angulation wheel, this is the upper angulation wheel, is fully 100% up. This is, I will show you, when this upper angulation wheel is 100% up, now this lower angulation wheel doesn't work. See, I am rotating but there is no any benefit. I will just show you this way. So, see, lower angulation wheel doesn't do anything. Reason being that there are wires inside. Those wires, if it is 100% stretched, then the lower angulation wheel doesn't work. But what we need to do, we have to see the fundus. So what to do? You have to rotate the entire endoscope like that. This is called as J maneuver. So you will rotate it and then you can see the fundus. Otherwise, endoscope will show its own. Endoscope will show its own. So we can see here that this is the endoscope going into the stomach, and after that you will turn it, you will see the pylorus, and then you will turn it upside, and here this is gastroesophageal junction. This is gastroesophageal junction. You can see endoscope is showing its own. Endoscopy is showing its own. This is gastroesophageal junction, because it is completely 180. After that you will do J maneuver and you will see the hiatus hernia, and it will be visible like a black hole, and you can identify. Then you have the foreign body retrieval. Sometime patient might have a denture, might have here, this is a small fish bone, and after going inside you can hold. Always hold it on one end. don't hold it on the middle, so that it will not do transverse arrest. Otherwise, it will slip also and go catch at one end, and then these small fish bone or coins or denture, which will be a lot of in your general practice, it will come and you can take it out. So, foreign body retrieval also time to time you have to do. So, it is done. Then you have one of the procedure, that is broken T tube removal. In this patient, T tube was broken. Here this is the guide wire going ERCP, and this is broken T tube, where laparoscopic CVD exploration was done, T tube was put, and at the end of 14 days, one surgeon want to take it, it was broken. Now you can do, and you can put a Dormia basket and try to just trap it. First you have to do a sphinctectomy. A sphinctectomy will be done at 11 o'clock position, and this is by monopolar cutting. You can cut it, the sphincter. You should not go beyond the mucosal fold to prevent the perforation. And this is sphinctectomy is finished. Now you will put a Dormia basket, and you can open the basket and try to trap the and pull it out. So this type of procedure can be performed, and it is very rewarding. 2-3 times it failed, but ultimately last attempt it came out, and then the T tube is out. For the same reason, it may be the big laparotomy, so the patient is saved. Again, endoscopic pseudocyst drainage. This patient has pseudopancreatic cyst. What you can do, you can inject the vasopressin, and after this is gastric lake. Gastric lake is very useful. By seeing gastric lake, you can orient yourself, because patient is in the left lateral position, so all the fluid get collected to the greater curvature, and gastric lake will be identified. After that, you can inject the vasopressin here, and then perforate the stomach, posterior wall of the stomach, and then you can enter into the pseudocyst here. This is the guide wire going into the cyst. After that, you can put a balloon dilator and you can dilate the opening. Here this is a balloon dilator, and it will dilate the pseudocyst communication with the stomach. So cystogastrostomy will be formed, and this is now dilating. With the dye, if you will dilate, you can see also the ballooning of your ballooning, and this is cyst and this is stomach. So it is dilated now. After that, you can put a drain, and you can put a stent. A stent is used as a drain, that is double J stent. So this is the double J going, and one J will be left into the cyst, another J will be in the stomach. So these type of procedures are very rewarding, and patient has immediate relief, and gastrocystostomy can be performed. This procedure is also performed by laparoscopy, in which you can go transgastric and fire the stapler. So this is over. Then you have narrow band imaging technology. There are two wavelengths, 440 to 460 wavelength and 540 to 560 wavelength, that is green wavelength. These wavelengths has a big advantage that it is absorbed by the hemoglobin. Wherever there is, and it will give you the completely neovascularization. It will show you the neovascularization. Whenever there is any atypical thing going on, malignancy is going to develop, it is a hypermitosis. And hypermitosis area has neovascularization. So in those situations, if you have a doubt, just stop it and press one button in the endoscope, that is called as narrow band imaging technology button. And after that, these all are neovascularization. So even the carcinoma in situ can be diagnosed. And this is very good nowadays. Even in the robotics also, narrow band imaging technology is coming. These all are neovascularization. That means it is a carcinoma state has started. It may be in situ, but you can take a biopsy from appropriate place. These all are neovascularization area, and you can take a biopsy from appropriate place. Not only that, you can do fulguration. Here you can see this is normal. This is normal. There is no problem. And here this image has a lot of mitotic activity is going on. That means it is atypical. It is abnormal. And this type of narrow band imaging diagnosis is only possible in video endoscope. In fiber optic endoscope, it is not possible. And video endoscope also, high-end video endoscope has this capacity, just like how the ICG we can see on the endoscopy. Then Los Angeles classification of GERD. Already you know that, but I will just tell you, any patient who come for the GERD, you have to classify the GERD. Standard international classification valid is Los Angeles classification. It has A, B, C, D. In A it is less than 5 mm. In A is equal to less than 5 mm, and it is in between the two mucosal fold. So this is LA grade A. We can see here these are the mucosal breaks, and small mucosal breaks and less than 5 mm. And it is between the two mucosal fold. So this is LA grade A. LA grade A easily cured by the medical therapy, but lifestyle changes has to be there. Smoking and alcohol must be stopped, and long-term medical therapy is required. Now LA grade B. In LA grade B, it is more than 5 mm. In B, it is more than 5 mm and doesn't extend beyond the two mucosal fold. So it could be 10 mm, 15 mm, and it is more aggressive. Problem of these patients that if they don't change their lifestyle, then within 1 year of drug withdrawal, 80% of the patient has recurrence. So a strict change should be required. Smoking should be stopped, alcohol should be stopped, and long-term proton pump inhibitor should be administered. This is LA grade B. Now coming LA grade C. In LA grade C, less than 75% of the circumference will be affected. Of course, it go beyond the two mucosal fold, but less than 75% of the circumference will be affected. But surgery is required. Any anti-reflux surgery, either LINX or TIF or fundoplication, you should do. So this is LA grade C. But you can see that more than 25% of the mucosa is healthy. Only less than 75% is affected. This is LA grade C. Now comes LA grade D. In LA grade D, more than 75% is affected. This is LA grade C. These all are LA grade C. Now you go to the last and the worst condition, that is LA grade D. At least 75% or more than 75% of the esophageal circumference is involved. Of course, it go to the multiple mucosal fold, and it's the worst condition of the GERD. This is LA grade D. These are broken mucosa and this is healthy mucosa. So more than 75% is affected. In these patients, medical therapy rarely works. Surgery should be immediately considered, and any anti-reflux surgery should be performed. So Los Angeles classification is only possible by endoscopy, and that is necessary now for the physician to do. Now POEM procedure. What is POEM? That is per oral endoscopic myotomy. That is called POEM. That is per oral endoscopic myotomy. POEM is used for esophageal atresia. How we do the Heller's myotomy by laparoscopy is completely different. Heller's myotomy by laparoscopy, I will just show you a glimpse here so that we can easily see the difference. That this is Heller's, which you do in the this is the esophagus is mobilized, and here the muscle is splitted. Can you see that? And here is the longitudinal muscle 3 centimeter, circular muscle 2 centimeter. This is the mucosa is popping up and you are splitting the muscle of the esophagus like that. This surgery already you will do in the next dissection, and I will demonstrate you how to do. You cannot do electrosurgery, so if oozing happens, you have to press by a sponge. And mobilization will be just like fundoplication, and after that you have to split the muscle to expose the esophagus. 3 centimeter longitudinal and 2 centimeter circular fibers has to be splitted. But this is an aggressive surgery because you have to do laparoscopy, you have to use a lot of energy and meticulous dissection. This is mucosa and this is muscle. Because there is a stricture, so this is laparoscopic Heller's myotomy. But same thing you can do by endoscopy. How to do by endoscopy? You will go with a current, and after that you will give vasopressin injection on the mucosa. This is the vasopressin injection on the mucosa, so that there will be transient ischemia. After that, with the monopolar plasma kinetic monopolar energy, you will split the mucosa, cut the mucosa, submucosa, and then your endoscope will be introduced in between the plane of the muscle and the submucosa. As we know that in esophagus there is no serosa, so muscle will be bulged out automatically, and after that with the monopolar you can cut the fibers, internal residual fibers. So I will take little forward fast. The detailed video you can download and you can see, but because time is constrained today, because you have to do hands on, this is the muscle cutting, and a small you can cut it, and that's all. And at the end, once all the muscle is cut, you have endoscopic clip here, and you can just join the perforated mucosa. So this is called as per-oral endoscopic myotomy. That's why I was telling you before also that there is no difference between the surgeons and the physicians today. All the physicians, after proper training, you can do surgery by endoscopy. You can do even the nodes also, natural orifices transluminal endoscopic surgery. So by endoscope you can remove appendix, by endoscope you can remove this hiatus hernia, by endoscopy you can correct the fundoplication. And the technology is now only endoscopist and non-endoscopist. That is only the technology, because there is no difference between surgeon and physician. It is just a matter of training. A surgeon who has training of ERCP he can do, and a physician also who has a training of ERCP he can do. So this is, now you can see a stricture is resolved, and this is gastroesophageal junction, J maneuver, no stricture. Now colonoscopy. Colonoscopy is a huge topic, and but I will discuss some of the important point. That this is a normal microvilli. This is the terminal ileum microvilli. I have read somewhere written that the microvilli of our human intestine, if you calculate the surface area of entire microvilli, then you can wrap the earth also. It is so huge. And this is just to increase the surface area of absorption. So this is terminal ileum, where you have a microvilli. After that you will come out, and then you will enter into the cecum. In cecum you don't have any villi. And this is the appendiceal orifice. Appendiceal orifice will be look triangular here like that. This is appendiceal orifice. And these are lymphoid aggregates. Lymphoid aggregates. If there are multiple lymphoid aggregates with the inflammation, it may be a sign of acute appendicitis. Now you will come further, then you will see the ileocecal valve. So this is appendiceal orifice, then come back again, and while withdrawing, and here will be ileocecal valve. Ileocecal valve will be little pale color and little globular, and it won't have the circumferential plica simulinaris. So at this point, these plica simulinaris will absent, it will join. So this is how you can identify the ileocecal valve. After that, again further you will withdraw, and you will see each and every haustra and plica we have to examine. So, haustra is depression and plica semilunaris is the circular folds. So, these are you can see, and these all has to be identified. You should always carefully see the haustras, because sometimes it may be diverticulosis which may be hidden by the fecal matter or fluid. And if excessive diverticulosis is there, that is one of the concern and you must take care. This is plica semilunaris and another is haustra. So, during colonoscopy, bowel preparation is very important, because if you don't have a good bowel preparation, there may be parasite, there may be some other fecal matter and your diagnosis will be affected. Again slowly you will keep on coming out, this is normal. Again this is all normal. Sometime you might have the vision of a small diverticulosis. After the age of 40, this type of a small diverticulosis is normal. But you should irrigate and suck and put the air little bit to distend it and to check it, and again coming out. Here it is, this is a small diverticulosis at this point. So, this is also normal, this is not any pathology, and again slowly come out. In the rectum you will not see any of the sigmoid colon will be more circular, and once you come in the rectum you will not see any haustra, and then slowly you can come out. So, this way routine colonoscopy can be performed. Sometime we can see these type of parasites also. These parasites are accidentally found, but you can look for and then you can take it out and you can send to the microbiologist that what is this. Then you have the ulcerative colitis. Ulcerative colitis, you have the patchy discoloration, more on the distal, less on the proximal, and you have to examine it, these type of typical finding of ulcerative colitis, and again biopsy is taken to confirm it. These all videos are present in your member area. Then you have polypectomy, sometimes there is a polyps and this is a sneer. These are the lobulated polyp, this is a sneer, you will go with the sneer and you can attach it and you can cut it out. Here this is a sneer and just loop and you go and tight it and put a monopolar current and it will cut out. If it is multilobulated, you have to cut it in the piecemeal, small pieces, it can cut out. Here it is cutting. And now it is out. You should be slow so that you should give time for current to work. Rapid sneering may bleed, and bleeding is the worst thing in endoscopy. And just you will drop it, leave it into the colon, it will come out with the fecal matter. Again you have the carcinoma of the colon, you have to go and do the biopsy. This is cauliflower-like growth and this is carcinoma colon. Again punch biopsy forceps are there which will take the biopsy. This is a biopsy forceps and you go and punch biopsy will be taken. So, ERCP already we have discussed before that this is a sphinctectomy going on, that will be at a position of 11 o'clock and you will cut the mucosal fold, then you can put the Dormia basket and then you can pull the stone out. Have you seen the ERCP procedure Dr. Khurana has must shown you? You didn't see till now? Okay, you will see the ERCP procedures. Probably tomorrow was Saturday, but Monday it will come, a lot of cases. Generally he keep the cases for this training program. So it is done and you can take it out. Then you have the indication of colonoscopy. Indications of colonoscopy, again it's an exhaustive list. Even a simple altered bowel habit and progressive constipation may be indication. In my opinion, every person after the age of 40 should go once every 5-year colonoscopy, so that it can rule out carcinoma in situ or any other problem. So, this is exhaustive list. Now, one procedure which I would like to demonstrate you for colonoscopy, which is just little away from the list, that is TEM procedure. TEM is called transanal endoscopic microsurgery. It was invented by Gerhard Busch. Professor Gerhard Busch was the head of the department of Tübingen University, Germany, and he has invented this, and it is widespreadly now used all over the world. TEM is one of the best surgery which you can perform if properly diagnosed patient will be there. For large endoscopically irretrievable rectal polyp, cancer, these are the indications. Benign indications are rectal polyp, carcinoid tumor, rectal masses, anastomosis stricture, anastomosis fistula, and pelvic abscesses. Malignancy either extreme beginning or extreme end. Extreme beginning means T1, T2 cancer without node, and extreme end when there is no any chance of any radical surgery, low anterior resection, then palliative surgery just to improve the lifespan of the patient, you can use TEM. Full colonoscopy before the procedure, full colonoscopy, rigid proctoscopy, and endorectal ultrasound is required. If the node is involved, don't do this surgery unless until no any other surgery is possible. Otherwise, low anterior resection will be performed. Patient should be positioned in this patient surgery in such a way that pathology should come at 6 o'clock position. So, if pathology is already 6 o'clock position, keep the patient supine. If pathology is 9 o'clock position, keep the patient right lateral. If the pathology is 12 o'clock position, keep the patient prone. And after that, this is a 40 mm proctoscope through which you will perform the surgery. It is a fantastic surgery. In this surgery, you have to use flexible instruments, articulating instrument, and physicians are also performing, surgeons are also doing it. Two companies are making the instrument. One is Wolf and another is Starch. Both the companies are making it. This is 40 mm proctoscope, and these are the curve instrument which you can use and perform. So, this is a stereoscope also which you can use. So, this is, I will directly show you the video how to perform this procedure. So, you will put the patient in the supine position. This is the original surgery from Tübingen University which is demonstrating, and here patient is in lithotomy position, and you have to give a lot of muscle relaxant. Why? Because these patients need 40 mm proctoscope. So, anal dilatation is required and patient should be fully relaxed. 4-finger dilatation of anus is required, and after that you will put proctoscope, put a lot of xylocaine or paraffin oil and xylocaine mixture, and then you will introduce the obturator with the proctoscope inside the anus. And after that remove the obturator out, and in the proctoscope you have attachment for light as well as air insufflation. So, this is adapter of the TEM proctoscope. Then you will put this is the air insufflator from above and light from below. After that there is a stand here, this is the stand. This stand has to be fixed here because your hand should be free to operate. So, this is a stand which is attached with the OT table, and you will bring it up and tighten it, and here it is tightened. So, it is done, and now you will start the procedure. First step of the procedure is tattooing of the tumor. You will take a monopolar and 2 centimeter lateral to the tumor margin, you will do tattooing. Do you know why? Because once you start separating this tumor, you may misinterpret the anatomy, because bleeding will confuse you and you may leave. You have to come with the healthy margins. So that's why tattooing should be done. And that tattooing is very helpful. You know, just like when we put a marceline tape in circular or needle in hysterectomy, we do tattooing. Yes, we burn that area so that we learn where we have to pass the needle. Otherwise, 1 millimeter plus minus can puncture the artery. Same way here. This is tattooing. Tattooing of the tumor is complete. After that, you will just hold it by left hand, and with the right hand, you can start splitting all the mucosa, submucosa. Left. And these are articulating instruments. So it will increase your manipulation angle, because just due to articulation, you will get at least 30-degree manipulation angle. Otherwise, it will be parallel to each other. So that's why they are flexible instrument. Is also used in single incision laparoscopic surgery also we have to use. And slowly. So I will take little forward, and it is cutting, and now entire tumor is resected out endoscopically. Who will do? Physician will do. So there is no difference as a surgeon and physician as far as, do you know, this specialization which we are right now taking and working on, those are 50-year-old specialization. That's the reason now in developed country they have revised there. So that's why they put master in minimal access surgery, or some endoscopists, they directly train them to do these type of procedures. Now this is the closure of the. Now one of the big problem that you cannot take a wrap, you cannot tie a knot. So there is a titanium bead which you can clamp the suture. So here the bite is taken, and there is a titanium lock and which you can apply, and it will act as a knot, and it will not allow the suture to go back, and then again keep on taking a continuous bite. This trick you can do in laparoscopy also. Sometime when you do valve closure, or sometime when you do the hernia surgery to close the peritoneum, and suppose you think you are short of suture, there is no suture, then what do? Pull the suture and clip the suture itself. Once you clip the suture, automatically it will work. So now it is closed. Now you can do again second layer of suturing also. This is second layer of suturing. So I will take forward first here, and ultimately at the end, this is also titanium is applied. This is polygalactane. So after few weeks, it will shed out, and it will come out this clip with the anus. It will discharge with the fecal matter. So TEM closure is also important, which you can do. Now conclusion of TEM is technically demanding, highly specialized endoscopic technique, can spare selected patients to go for laparotomy and low anterior resection, or laparoscopy can be avoided, but most important is patient selection is a paramount. Unfortunately, in our country, patient comes once it is too late. So in routine colonoscopy, if it is identified, TEM is best. But sometime it is too late, full thickness involvement with the nodal metastasis, there is no place for TEM. So now risk to the endoscopy. There are a lot of risks. One is allergic reaction. So any dye, gastrographene, or anything you use, contrast, you must try to check the allergy. Second is punctured organ. This is one of the major cause of mortality. Second major cause is perforation of the colon, perforation of the duodenum, perforation of the CBD. This happens. Then oversedation. Always low acting, short acting diazepam has to be used, like midazolam. That's why, because it has a less respiratory depression, but sometime we might have the oversedation. So ideally, in the developed country, whenever they do endoscopy, they do under the presence of anesthetist. But in our country, every time anesthetist you cannot be available, you may have to do. So always airway, then the laryngoscope and all the other things should be present. Oxygen also should be present, and monitoring also should be done, because there may be risky. Infection is one of the big problem in the heavily loaded hospital. Ideally EtO2, ethylene oxide sterilization should be there. But problem is ethylene oxide sterilization has detoxification time, because it is toxic agent. So detoxification, total time taken is 4 to 6 hours. Now this is a big problem. So that's why now the developed country, what they do, the shaft part of endoscope is coming disposable, which you can attach, use in one patient and unattach and throw it. The shaft part, which go inside the abdomen, is disposable. So you don't need a sterilization, every time you can use new. But of course in our country we cannot do, so we use Sidex. But Sidex should not be used, Rapid-Sidex should be used, that is para-ophthaldehyde, and at least half an hour must be immersed. But in heavily loaded hospital, where in one day they have to do 20-25 surgery, sometimes they don't give proper contact time, and infection of HIV and hepatitis is one of the concern which we must think about. And we should do proper care of disinfection of the instrument. Now, technical aspects are also important, that check the scope, air, water, suction, angulation wheel, leak, we should check for light source, processor, suction machine, all the accessory, check for indication of the procedure, and consent also should be taken. You know, sometimes you have not told the patient what you will do with the patient, and patient get panicked. And also you should try to get the consent of high risk factor. We should also explain about the procedure to the patient and family, and that way it will be better. Now little bit I will ask to show you. Let us finish this lecture. So this was the endoscopic lecture. Now I am going to demonstrate you the procedure. How to? Is there any question?
Can we use ketamine?
Pardon?
Can we use ketamine?
Can you?
Can we use ketamine as for
Cetrimide. Ketamide. Ketamide also can be used. Some people they use ketamide. That is also can be used. So I will show you here. But ideally you should use para-ophthaldehyde, because it is very good for sports also. Sports also. So now I am going to demonstrate you the procedure. Procedure, once you will switch on, either focus kar lo. Procedure once we will see. This is the processor, niche karo. And processor, once you will switch it on, turn on, then it will check its own everything. And what are the buttons in the processor and how to fix it, I wanted to show you. On karo. So here, this is thoda sa aur focus karo. This is to select your data source. Means endoscopy, in video endoscopy, it is necessary that you have to give the data to the patient. You need to give the video of the endoscopy or at least picture. So if you see here, this way, this is a scope. This is directly going to the printer. This is video tape recorder. This is S video recorder. This is video disc. And this is the digital file. It has its own digital file. So this you will select the data source, which data source you want to select. On the back it has all the attachments. Like it has attachments for printer, color printer, it has attachment for video tape recorder, it has attachment for S video recorder, it is attachment for hard disk, and it has attachment inside inbuilt digital file. So this is to image source. Now if you want to reset it, you press 3 seconds, it will get reset. This is for printing. If you will press it, directly it will print the page. The page which you are paused, you can freeze the page, freeze the image by your finger button, and then you can print. This is for digital enhancement. This is low, this is medium, this is high. So if you want to perform the surgery and suppose you want little more bright and more digital pixels, then you can press, it will be digital enhancement. This is the iris. Normal iris is peak, normal iris is average. If you want iris to change, it will go peak. That also will improve the quality of light. And this is manual color saturation. If you want, as we know that there are 3 basic color, red, green and blue. So you can increase and decrease any color. If you want to increase any color, like red, you can increase it. Blue or green, you can decrease it. And this is the blue also, you can increase and decrease. and this is HSR, that is hue saturation ratio. If you want that color should be more saturated, you can increase and decrease it. So this is how you will do it. After that, I will show you how to program it for you. How to program it for you, that I am going to demonstrate you. Here to program, we will see here that this is the keyboard. In the keyboard, you have different button, and in this keyboard, you will press this escape button. And once you press this escape, it will go to the, on the screen you will see, it is go to the user preset call. User preset call means you can call your name, but before that you have to enter your name. So I am going up, and after going up, you can press the user preset entry and enter. User preset entry. Now there is no data right now, I am putting the data now. So you can type Dr. R. K. Mishra. Suppose you will type it like that. Sorry, just going down. Yes, enter the data, and then you can type your name. Yes. After that, go down. Are you sure? No, not sure, because other things are still has to set. Then this is freeze mode. Freeze mode is of two types. One is filled, another is frame. You can select. Now this is a scope switch 1. Switch 1 is right now freeze. I can change it to field mode, I can change it to release, I can change it to iris, I can change it to digital enhancement, I can change it to contrast, I can change it to automatic gain control, I can change it to do the video tape recording, I can change it to printing, I can change it to the playback. Playback means digital file which is recorded, it will play also. And you can change it to shift switch, you can change it to a stopwatch, you can change it to removable disk. If you want to record in your pen drive, you can do that, and external image sources and options. So it has a lot of function, and you know this is up to you which function you want to keep. So this is freeze, I am keeping it to the freeze only. This is iris, I am changing to digital enhancement. This is print, and this is I am changing to suppose video tape recorder. Suppose I have changed it. After that it will ask, are you sure? I will say yes, and I am sure. Now it will save the data, and now data is saved. Now what is the advantage I will show you. Endoscope de do. That ye endoscope de do. Yes, I will show you that when I will press the particular button, it will do the job. So let us see that. Suppose इसको यहाँ रखना होगा, इस पे, just इस पे रखो, so that they can see. So suppose it is here, and थोड़ा सा सर नीचे कर लो. Yes, you can see here, this is showing the image. Now if I will press the button number 1, it will freeze. See, image is frozen. And after that I will press button number 3. See, it is writing what? It is writing that no connected VTR. Here it is writing no connected VTR, means video tape recorder is not connected, and otherwise it would have been connected, it will start recording. And in that button number 4, what I have done, I think no connected color video printer. So it is no connected, otherwise it will do. So, and this is second one is so different. If I want to unfreeze, I will press it 1 again and it will unfreeze. So it has a lot of functionality. Once you will do the hands-on right now, then first you should try to fix the programming how to do. And all of you can save it by your name and try to recall it. During the lab, we will demonstrate you again how to do this programming during the live session, so that you will understand better. Right now it is far away, so it will be difficult. So any other question regarding endoscopy? Any other question? So it's a vast topic, It is time is less, although you can. So all the other videos, please try to download and get it there. So thank you very much. Just have a coffee, and after that come to the lab. Yes.
You said about we should check the leak before going to the procedure. How is?
Do you know what happened? That you have to take the tip of the endoscope in a water in a glass water bottle, and then press the irrigation. You will see bubbles coming out, and then press it more. Then you will see fluid coming out, and at that time you should check the leak outside. Sometimes what happened? The bottle is not connected tightly, and all the fluid is leaking from there. Just like when we do suction irrigation, then sometimes it leaks from outside. So leak means connection of the air and fluid. So that should not leak. Otherwise, it is leaking outside and you don't have an appropriate distension of the bubble, isn't it? And then you will struggle. So leak means this. And how to check the leak? Thoda leak check karke bata dena abhi. In the fluid medium, you have to, just like puncture tire test how we do, and you see that bubbles should come out with a glass of water. Once you put the finger on the front button, and if bubbles are not coming, that means air is leaking somewhere. And then you will struggle during the procedure because you want to distension and it won't distend the lumen. So these technical things should be checked before. And exactly same way you press it and you will see fluid is irrigating or not. If fluid is not irrigating, that means connection of the bottle is loose and it is leaking from there only. All the fluid is coming on the floor. So leak means this. Pardon?
White balance.
Do you know white balance it need? Here it is already a button there, white balance, we will show you. White balance is necessary, focusing is not necessary. Because it is an endoscope, so it is a CCD, here it is a chip on tip technology. There is no lens ahead of CCD. You got the point? So in laparoscopy, in front of CCD there is lens, isn't it? So you have to focus. But here what is the advantage? That this is chip on tip technology. CCD, which is in our head of the camera, is at the end of endoscope. So there is no any lens ahead. So you don't need focusing. Focusing is not required. But just like your mobile camera, there is no lens in front. So you don't need focusing. But SLR camera need focusing. So exactly same way it is not required. White balancing has to be done. So thank you very much. Now please just go to the lab and we will demonstrate you how to do endoscopy.